Good evening. I'm Pooja Banerjee from IJCP Group. August 23rd to 29th, 2021 is Wound Awareness Week, focusing on the awareness of chronic wounds among healthcare professionals and the general public. When we talk about burn injury, the burn wound is a dynamic living environment that will alter depending on both intrinsic and extrinsic factors. Optimum treatment of the wound reduces morbidity as well as mortality in case of large wounds. It also reduces the time for healing and return to normal function. Considering the importance of burn injuries, today's webinar is on the topic Understanding Burn Injury and New Approaches to Burns Injury Management and Dressings. For this, our esteemed guest is Dr. R.B. Ahuja. Dr. R.B. Ahuja is a senior consultant in plastic and aesthetic surgery at Burns Plastic and Aesthetic Surgery Department at Sir Gangaram Hospital in Delhi. In his illustrious career, he has several publications in peer-reviewed national and international journals, awards, and recognitions from the Associations of Plastic Surgeons of India and NBE, among many others. In the past, he has served as the president of International Society for Burn Injuries, Association of Plastic Surgeons of India, and National Academy of Burns India. He sits on the editorial board of many important journals, some of which are Burns and Trauma, Plastic Surgery, Annals of Burns and Fire Disasters, Journal of Plastic Reconstructive Aesthetic Surgery, and India Journal of Plastic Surgery. He is also the founder president of the Asia Pacific Burns Association. He has been invited as a guest faculty to various conferences and educational institutions. He was also the visiting professor of AIMS Rishikesh in 2020. He is also the visiting professor to many universities in India and abroad. We are grateful to have you, sir, on the webinar today. We welcome you to the webinar. Uh, I hand over with this, I hand over the stage to
Thank you very much, Pooja, for this kind introduction and for building up the background for the burn injuries. Burn injuries are certainly very vital for us to know, especially for the general physicians and for the surgeons, because not just because they cause a devastating kind of an injury, but also because India, embarrassingly, is the burn capital of the world, and there are so many patients which who need our care that I think we should all be acquainted with the burn basics of burn management. It is very unfortunate that burn management is not taught in our undergrad courses and very sparingly in our MS surgery courses. So in this short time of 40-45 minutes, I'll give you an overview of how we manage burns in current times and what are the newer dressing materials which are available to us. And In the beginning, I'll also acquaint you with what type of burns we have and what is the kind of a first aid that we can deliver to these patients. So my disclosure is this talk is sponsored by Convatec. Burns can be of several origins. It can be a thermal injury from contact with flames or because of a hot surface. It can be scalds when we come in contact with hot liquids and that causes a burns. It could be from acids and alkalis. It could be from electricity, from radiation injury, or from frostbites. Some of the soldiers who are posted in Sichuan glaciers and such heights, they commonly suffer from frostbites. This is the kind of first aid for thermal burns which we
sorry,
all.
I'm interrupting you. You haven't shared your slides.
Uh, I'm sharing my slides. Is it all right now?
No, sir, we can't see it.
But I am sharing it.
I'll ask the IT team.
Sorry to interrupt you, sir. Sir, please click on share screen.
Yeah,
Fourth
I've done
option in
it.
the bottom.
Can you see it now?
No, sir.
Screen now?
Not yet, sir.
I did press that sharing screen.
Share screen. Then, sir, second option, share screen. Then entire screen.
Yeah, entire screen is selected.
Uh, okay. Yeah. Now it's coming, sir. One second.
Yes.
Yes. Yes.
Now we can see. You can just
Yeah.
yes.
Visible, sir.
So
So this I did discuss. So the first aid for thermal burns that we all need to be familiar with is that the foremost thing to do is that you have to stop the burning process, whether you pour water over it or you put a thick blanket over the burning patient. Then you have to stop, drop, and roll. So this is very commonly taught in schools, in Western schools, that you stop immediately, drop on the ground, and roll over, and that will smother the fire. Then you have to cool the burnt area with the tap water. It need not be sterile. Any tap water with normal temperature would do. And you have to remove any constricting clothing or jewelry which the patient might be wearing, and then do an ABCD of assessment. I'll come to this later. Uh, and you have to consider that the burn patient is suffering from multiple trauma until it is determined otherwise by another experienced person. Cover the patient with a clean sheet and transport the patient to the hospital. So if you have suffered electrical burns, you have to just look, do not touch anything at the moment. First, turn off the source of electricity, move the source away with a non-conducting agent which you may have, a stick or something which you may be having around you. And then you come to again the ABCD of resuscitation, which is you ensure the airway is maintained, the cervical spine is protected, the patient is breathing and ventilating properly, and then look at his circulation, look at the disability or neurological assessment, and ensure the environmental control. You may have to remove all the clothes and expose the patient. So all this you may not be able to do at the site. Sometimes you will have to wait for the first responders in the advanced uh, ambulance which may reach, or in the hospital. But this is in general what we advise on first aid, and most of us should be familiar with this. At least most of the doctors should be familiar with this. If there is a chemical burns, generally this is either sustained, mostly sustained in the industry, but sometimes sustained in at residence also, and sometimes of vitriolage also. So you have to wash the burnt area with plain water immediately, and you have to irrigate for at least 15 to 20 minutes to let the chemical run away, run out, and not let seep in. You have to dilute the effect of the chemical, give an eye shower for a similar period of time if it has gone into the eye, and then remove that contaminated clothing completely. Again, you can cover with a sterile sheet, I mean any clean sheet, not sterile sheet. And but do not use any neutralizing agent. If you know that an acid has been thrown on a person, or the patient is because of an alkali has got burned, if you give a neutralizing agent, it will cause an exothermic reaction. It will lead to further burning. So avoid that. Just plain water is sufficient antidote or kind of a first aid in these cases. A substance called diphothrin has now become available in India in industry also. Obviously, it is not available at residence, and it is of no use if you reach the hospital because it has to be given as a first aid. This is a common chelating agent and an amphoteric molecule which is useful in neutralizing whether it is an acid or an alkali burns which has been suffered. So in many cases of resuscitation, it is done by advanced life support team in Western countries. In India, it may or may not be available depending on the kind of a tier level of the city that you are in. And if there is an advanced life support team which is available, they will start the fluid resuscitation immediately by inserting a wide bore IV cannula. And the resuscitation that they use is a Parkland's formula for with ringer lactate. I'll come to this subsequently, what is the resuscitation fluid and how it is done. And you insert a Foley's catheter to monitor the urine output. Again, cover the patient with a clean cloth and nothing more than that. A few slides about the pathophysiology of burns. Burns will lead to coagulation, a coagulative necrosis because of the high temperature touching the skin. And if you look at this Jackson zones of burns, you can see that the centermost umbra of the area is the zone of coagulation where there is the maximum injury. The surrounding it is the zone of stasis where there is a bleeding, where the blood supply has become stationary, and then there is a zone of hyperemia, which is the penumbra of that. So all burns, they are generally of the mixed type. You can have a third degree burn, a second degree burn, which are intermingled. So it is sometimes, it is generally not seen that most of the burns are third degree burns. But of course, you can have the whole body may be first degree burn or the whole body may be second degree burns. But generally for third degree burns, unless the body is completely charred, you don't see complete third degree burns. And the amount of depth of burn, it depends on the temperature at which the burning occurs and the time to which it is exposed. The significance of this is that if you have a temperature of 43 degrees centigrade, then the patient will never get burned for any level of time of exposure. But as the temperature keeps on increasing, then you may sustain burn within a few seconds. Like if you have an 80 or 90 degrees centigrade temperature, you may sustain burn in a couple of seconds only. As soon as the skin gets burnt, there is a release of inflammatory mediators like histamine, serotonin, prostaglandins, and bradykinin. And these inflammatory mediators, they get released in the circulation. They increase the capillary permeability, which leads to leakage of proteins into the extracellular fluid space, which leads to edema in the burnt skin of the area which is burnt. Now, this is all right, but when the burns are more than 30%, then these inflammatory mediators lead to leakage of proteins and fluid in the non-burnt skin also, because there is so much of inflammatory mediator in the circulation, and it leads to third space fluid losses, which are quite large. And herein lies the role of resuscitation. So any adult more than 25-30% burns requires resuscitation because of third space fluid losses. So all these changes, the fluid shifts, the cell damage, they lead to biochemical changes. If the cells are damaged, obviously the potassium inside the cell will come out, and it can lead to hyperkalemia. Generally, we do not see hyperkalemia even in electrical burns, because if the patient gets adequately resuscitated in times, so this hyperkalemia is not noticed. But there is definite hyponatremia because of the fluid loss. And because of the fluid loss, we also see hemoconcentration. The osmolarity goes up, the hematocrit, hemoglobin go up due to the dehydration, and the patient requires immediate and adequate resuscitation. Because of these fluid shifts, the patient also goes into metabolic acidosis, which also needs correction during the resuscitation. So there are phases of metabolic changes. There is an emergent phase, which is in the first 6 hours when the patient is having a lot of pain. There is a lot of release of catecholamines, which lead to tachycardia, tachypnea, a mild amount of hypertension, and some anxiety. But following this is the important phase of the shifting of the fluids because of the inflammatory mediators, and this phase can go up from 6 to 24 hours till the permeability of the vessels it gets restored. And this leads to a shift of the intravascular fluid to the extravascular compartment, and it leads to massive edema, as I've already alluded to. There is also plenty of metabolic changes which are taking place because of burns, more so in extensive burns, and they can start at a couple of days post burn, and they can go on for weeks and months, and sometimes in major burns till all the wounds are healed, the patient can continue to remain in a catabolic stage. So much so that the basal metabolic rate can rise up to 2 times the normal. If you see this slide here, in fractures, if you have a fracture, the metabolic rate may go up by 10-20%. If you have sepsis, the metabolic rate may go up by 30, 40, 50%. But if you have burns more than 30%, the metabolic rate can go up by 100%. And if you see the slide on your right, you can see that there is a continuous rise in the metabolic rate till it plateaus at 30-40 degree total body surface area burns, and then it doesn't rise any further. So this metabolic rate has to be kept in mind. It increases the body's need for nutrients, and we have to keep it in mind when we are doing replenishments. Cardiovascular changes are happening because there has been a fluid shift, and at the same time the myocardial contractibility is decreased. Possibly it is stated it is because of a tumor necrosis factor which is there in the circulation at this moment, and the fluid shifts, they also lead to systemic hypotension, and as a result of this the end organ perfusion is decreased. Especially the splanchnic circulation, it goes down, it leads to ileus, and we have to keep in mind that if patient has burns of 50-60% or over, the patient may be having severe ileus, and you don't have to give orally anything to the patient. The respiratory changes are there also because of inflammatory mediators, and again because there can be inhalation injury. I'll discuss inhalation injury subsequently, but because there are inflammatory mediators, it can lead to bronchoconstriction. In severe burns because of inhalation injury, you can have adult respiratory distress syndrome, and I'll come to this a little later. These are some of the changes which are happening. Along with this, we have immunological changes which happen. You would appreciate that most of the burns which happen are in poor patients, and they have a very low serum protein level to start with. And when all this intravascular albumin and protein that is being lost in the extracellular compartment, it further decreases the level of proteins which are there, and there is a non-specific downregulation of the immune response in burn patients, which is both cell-mediated and because of humoral pathways. And this I just mentioned that it could be because of loss of proteins, and there is inadequate replenishment which is taking place. So most of the times we are worried about this and giving patients either plasma or albumin, and these are very expensive to replenish. A bit of understanding about the depth of burns. So we classify burns as first degree, second degree, divided into superficial and deep, third degree. So what is a first degree burn? A first degree burn is just when the epidermal surface is burnt. I'll show you an example subsequently. When just the first degree burn happens because of sunburns or something, this is not counted towards the calculation of the fluid requirement. A second degree burns is superficial, is when a part of the papillary dermis is also burnt along with this, and a deep dermal burns or a deep second degree burns is when the burn depth has reached the reticular dermis. A third degree burn is when the full thickness amount of skin, the complete epidermis and the entire papillary and reticular dermis has been burned and the burn has reached the subcutaneous fat. It is third degree burns. Some people would like to classify a fourth degree burns also, which reaches the muscle, and sometimes when it reaches the bone, they call it fifth or sixth degree burns, but they are of less consequence. So, discussing about the first degree burns, you can see the picture on your right. This is a patient with first degree burns. It involves only the epidermis, and this kind of a burn you sustain when you are when you are sunbathing or you are under an ultraviolet light for a long period of time. The tissue is extremely erythematous, very painful, and the tissue will blanch with pressure. So this is an indication this is a first degree burn, and it heals within a week with no scarring at all. And like I mentioned, first degree burns you don't need to use in calculating the fluid requirement, and if a patient has suffered just a first degree burns, he doesn't need any resuscitation at all. Everything can be managed by oral replenishment of fluids. A second degree superficial burn which involves up to the papillary dermis, you can see here there is a thin layer of dead overlying skin which has got burnt, and there is an exudation of fluid and protein. This kind of an exudation, it can bulge out the superficial thin layers, the dead layers, and lead to a blister. Because the nerve endings are exposed and they are in plenty, these burns are very painful. And the good thing about these burns is that they heal automatically in 14 to 15 days. You just need to protect them. It is very rare for a second degree superficial burns to get complicated. The situation is a little different with second degree deep dermal burns when the burns have reached up to the reticular dermis. There is a larger thickness of the skin layers which are burnt, which give rise to a whitish kind of an eschar, which is a kind of a waxy material. It is pale and mottled, and because there are not many blood vessels in it, it does not blanch on pressure. Most of the nerve endings have been destroyed, so it is painful, but less sensations are there. And this also has the potential to heal by the residual sebaceous glands and the sweat glands which may be there, which are remaining there in the underlying portion of the reticular dermis, and it heals in 3 to 4 weeks. But the unfortunate part is that when it heals in 3 to 4 weeks, it gives rise to hypertrophic scarring. We'll discuss the implications of this, how to treat this better subsequently when we are discussing the management. And then we have full thickness burns when the entire thickness of the skin up till the subcutaneous tissue is burnt. The skin looks black, it is charred, parchment-like skin. Sometimes the coagulated superficial veins may be visible through it. All the nerve endings have been destroyed, and so the area is completely insensate, and there is complete destruction of the tissue and the structures within that. They cannot heal automatically because the healing by epithelialization is not possible, as all the sweat glands and the epithelial appendages, they have been destroyed. This can only heal by surgery, by removing the eschar, and by skin grafting. So something about how do you estimate the burns. These are the charts for adults. These are called the rules of 9. The head is 9%, the head and neck. Each upper extremity is 9%, each lower extremity is 18%. The trunk, anterior and posterior, is 18% each, and 1% for the perineum. So it's very easy to calculate. You can have a rough idea of the extent of burns by these charts. However, in children, this area of the head and neck is larger in proportion to the body, and therefore when we are calculating the extent of burns in children, we subtract from the legs and add it to the head. So as the child grows, then we keep on reducing the amount of the surface area of the head and keep on adding it to the limb and the trunks. So this is the rule of 5 which we follow for children. One of the very simple rules to follow, whether it is children or adult, is that one palmar surface of the patient is generally equal to 1% of his body surface area. So this is a very simple way. If you don't remember anything else, you can calculate the extent of burns by this method. And these charts, which are the Lund and Browder charts, are extremely accurate charts. They cannot be remembered. They have to be put up in the burn units. And if the residents are careful, they can use this chart and they can map out the extent of burns, not just the extent of burns, but how much of it is full thickness, how much of it is deep dermal, and how much of it is superficial. It can all be charted if these charts are available to the resident in the burns unit. So we have admission criteria for burns. All burns, they do not need to be admitted. Many can be treated. Most of the burns can be treated on an outpatient basis. But if the adults suffer more than 15% of the body surface area and children more than 10%, they should be admitted. Burns of full thickness burns, if they're of any amount, more than 1%, they should generally be admitted because they will not heal on their own. If there are circumferential burns on the thorax or extremities, even if they are less than 10 or 15%, they should be admitted because it can lead to vascular compromise and it will require eschorotomies or fasciotomies. And if there is presence of just inhalation injury, that also requires admission. If you remember the Upahar tragedy, none of the victims, they had any burn injuries at all. They all suffered inhalation injuries and they all were admitted to the hospital. If you have burns of the special areas which are functional and important, like face, hands, feet, genitals, perineum, or skin over a major joint, irrespective of the percentage, these patients, they have to be admitted because you have to treat them carefully so that the function gets restored. A chemical injury, electrical injury, or a lightning injury of any extent, it has to be admitted because you need to evaluate and resuscitate properly. And then also patients who have a coexisting major trauma. A patient may have burns and he may fall from a height and fracture, or a patient may have a pre-existing condition like he may be severely diabetic, he may be having psychiatric problems. So all these patients, they also are special patients and they all need to be admitted irrespective, regardless of the percentage of burns they may have sustained. Inhalation injury is very important to diagnose and suspect. I'll come to that in the next slide. Let's see what is inhalation injury. You can burn the airway, the upper airway, which is above the glottis, when you can have swelling and erythema in the mouth, in the oropharynx, in the nasal cavities. There will be a change in the voice and stridor, and this presents very early, within few hours. Or you can have a lower airway tract injury. You can have combined also, of course, which can be caused by inhalation of steam or smoke, and this will present as cough or a respiratory distress. The patient may have carbonaceous sputum, he's bringing out that sputum which is black in color, and the patient may also undergo encephalopathy because of hypoxia. He may go on to have ARDS. And occasionally, we don't encounter this very frequently, but you can have a carbon monoxide poisoning or hydrogen sulfide poisoning, because if the patient has inhaled smoke from burning plastic or wood or toxic materials, again, this will present as cough, respiratory distress, and altered sensorium. So how do you suspect inhalation injury? First of all, the patient will give you a history of having sustained burns in a confined environment, like the patient was in a kitchen and there was no ventilator there, or similar kind of an environment. If you examine the patient, there will be singed facial hair, the nasal hair will be burnt, patient will have facial burns and burns of uh, maybe 50% or greater. They have a larger chance that the patient would have also inhaled the fumes of the clothes or the surrounding tissue or the surrounding material which may have got burnt. If you examine the patient, there will be erythema. If you ask him to open the mouth, there will be swelling, erythema on direct visualization. There can be changes in the voice, wheezing, labored respiration, carbonaceous sputum, as I mentioned. But I put them in red because you don't have to wait for all this. If you are getting resuscitated or getting treatment in a good burns unit, you should have preemptively intubated the patient before the stridor develops, because once the stridor develops, it becomes too late to intubate, and then the only recourse is a tracheostomy. So to do this, good burns units will do a diagnostic bronchoscopy to visualize the pharynx and look at the status of the vocal cords and surrounding and the lower bronchial tree. And if they suspect that there is any evidence of erythema or inhalation injury, they will immediately intubate prophylactically. So you don't have to wait for an altered mental status or a wheezing or a stridor to develop before you take any action. Inhalation injury is managed by monitoring the oxygen levels, by acid-base balance measurement, keep the patient in a propped up position, give chest physiotherapy, prophylactic antibiotics only in case of inhalation injury, and like I mentioned, hoarseness is a sign of impending airway obstruction. And again, I repeat it that you have to preemptively intubate before the stridor develops. Some of these patients, they require positive pressure ventilation if they are not able to maintain the saturation, and this is to keep the alveoli patent. Resuscitation, there are many formula for resuscitation, and they are all indicative. You can start resuscitation with any of the formula you are familiar with, but one of the formula which is most commonly practiced around the world today is called the Baxter's formula. And according to this, you give 4 ml of ringer lactate per kilogram body weight per percentage of burns in 24 hours. Half of this calculated volume is given in the first 8 hours, and this first 8 hours is calculated from the time of burns and not from the time of admission to the hospital, which may be delayed. The second half of this ration is given over the next 16 hours by continuous monitoring of the urine output, which has to be maintained at half to 1 ml per kilogram per hour. If the urine output is not maintained at this level, then you have to increase the rate at which the fluid is infused. And if the patient is maintaining this, so actually then you have to reduce the infusion. So basically these formulae are all indicative. They are not hard and fast that you have to give that much amount of fluid, and ultimately you have to titrate the amount of fluid infused with the urine output which the patient is maintaining. At our institute, we give 3 ml per kilogram per percentage instead of 4 ml because it was noticed by us 3 decades back that sometimes if the residents, they stick to 4 ml per kilogram per body weight per percent, and the urine output monitoring is not very strict and the titration is not done properly, the patients, they go into fluid overload, which can cause problems. So it is better to start at 3 ml and then to increase it depending on the urine output. And this has become a standard worldwide in the last decade or so. Like I said, there is monitoring of the fluid resuscitation. There is nothing like urine output. This is the best way to monitor a fluid resuscitation. CVP is not necessary. Generally, it is only occasionally required when the patient has delayed resuscitation because the patient has arrived more than 6 to 8 hours after the sustaining burns and has not received any resuscitation in that period, then you would like to insert a CVP line and maybe start 2 IV lines and then open the IV fluid just like a tap so that the CVP gets restored, and then you decrease and titrate the further infusions by the amount of urine output the patient is producing. So you also monitor the acid-base levels. The hemogram is done daily. You do the kidney function test. The electrolytes are daily because the patient is under tremendous amount of infusion. So these have to be looked after. Serum albumin and LFT, you should have a baseline at the time of admission, and then you assess weekly. And if serum albumin is seriously falling, then you have to replenish with plasma or albumin. Chest X-ray is only done if you suspect inhalation injury, and if you suspect electrical injury, then you may do you may do an ECG if there is any suspicion on the pulse rate because of some arrhythmia or something. Cardiac enzymes are only rarely done in electrical injury unless there is some suspicion of serious cardiac damage. You can do a urine routine and microscopic examination. Wound swab may be done for culture and sensitivity after the 3rd or 4th day. Initially, when the patient comes with burn injuries, and if you take a wound swab, that will obviously always be sterile because the bacteria, surface bacteria, have also got burned in the process. But after 3rd or 4th day, it can be helpful if you have a wound swab, because should the patient go into septicemia subsequently, you know the flora and the sensitivity report so that you can start appropriate antibiotic therapy at an appropriate time. Something about further about the electrical injuries, like I said, you monitor the ECG and cardiac enzymes only if it is extremely necessary and you are suspecting atrial fibrillation or something like this. But electrical injuries are notorious to cause compartment syndromes in the extremities, and most of the times it is the extremities which sustain electrical injuries. When the muscle necrosis takes place, it leads to compartment syndrome. The fascia becomes tight, the blood supply to the periphery is reduced, the sensations get reduced, and this requires an immediate and early fasciotomy, which is limb saving. And you have to be carefully monitoring such patients every hour or so, otherwise you will lose the limb. And this is the importance of transferring the patient to a good burns unit. In electrical injuries, because there is myoglobinuria, if there is a large amount of muscle necrosis, you have to maintain a higher urine output. It may be that you may need to infuse at 4 or 5 ml, but you don't start at 5 ml, you start at 3 or 4 ml, and then you titrate and give the fluid accordingly. But sometimes it is seen that if there is an extensive electrical burns, you may need more than 4 ml fluid. Whatever be the percentage of burns and electrical burns, you still have to catheterize the patient because you have to check for, see the urine output, the resuscitation, and check for myoglobinuria. Because in electrical burns, there is a lot of concealed damage which is there in the body. It may not all be on the surface, which you see. That may just be the tip of the iceberg. The burnt area underlying may be much larger in extent, and therefore this is the burnt area which is the concealed, which we don't know, which we cannot see. Therefore the volume of fluid required is larger than what we may estimate from the surface burns. And these patients, because of myoglobinuria, also have they can go into acute renal failure more often than a normal thermal injury patient. Most of these patients, they are in pain, extreme lot of pain, and but pain can be adequately controlled by giving any of these tramadol or Fortwin or midazolam. But pain also gets controlled if you do a proper dressing, because the nerve endings which are exposed to air and to friction, they have to be covered with a proper dressing, and that also is required to control the pain. I must caution about giving prophylactic antibiotics in burns. In burn units, prophylactic antibiotics are never given, because if you continue to give prophylactic antibiotics to all the patients over weeks and over months and years in the same burn unit, the normal bacteria of the ward which are there, they become resistant to these antibiotics, and then you are left with no choice. So in the early postburn period, you don't need to give this, but you don't have to hold back antibiotics for a very long period of time. If the patient is showing any sign of going into septicemia on the 4th day or 5th day or subsequently, you must start antibiotics immediately. Broad spectrum combination of antibiotics which takes care of the entire spectrum which may be there nosocomial in your wards. And then you can also start these on the basis of the wound culture swab reports that you may have obtained on the 3rd or 4th day. So this is the value, but there is no point in starting prophylactic antibiotics in the early postburn period if you are in a burn unit. Nutrition, as I mentioned, is extremely important. You don't give anything for first 24 hours to major burns, because there is a splanchnic ileus. It causes nausea. The patient can have is a potential for aspiration. Instead, you put a nasogastric tube if the patient is in ileus. But having said this, you start oral resuscitation as soon as oral feeds as soon as possible, maybe after 24 hours or 36 hours, because the gut must get its feed to start the peristalsis. Many times in major burns, we give pantoprazole and things like this to prevent stress ulcerations. Oral root seems to be the best for nutrition. Oral root is preserved, it is not burnt, and it is the best route for giving oral nutrition. Total parenteral alimentation is never ever required in burns. You may need an IV supplementation of diet, but total parenteral nutrition is not required. Patients need high protein diet, something like 2 grams per kilogram per day. And there is also a very high caloric requirement along with these supplements which are mentioned here. There are formulae to calculate the amount of nutritional requirement, 25 kilocalories for each kilogram of body weight. This is the normal basal requirement, plus 40 calories per percentage of TBSA burn, which is due to the excess metabolic rate. And if you have a 60 kilogram man with a 40% burn, this translates into 3,100 calories. And you can imagine if a patient has higher percentage of burns. It can become very difficult to give so many calories by the oral route, and therefore IV supplementation becomes important. Similarly, there are formula written here for juniors where there is a higher calorie requirement in the basal setting, and just 35 for each percentage of burns. Wound management, very important for the general physicians also. Obviously, you will administer tetanus toxoid as appropriate. If the patient has got small burns, which can be managed on an outpatient basis, and very small blisters are there, you do not open these blisters, you just aspirate and leave that overlying thin dead skin there only, which will act as a protective dressings. However, if the blisters are large, they should be de-roofed, and this you don't do in your clinics. This has to be done in a unit. They will de-roof it, clean it, and then dress it. Doctors will apply a non-adhesive dressing like a paraffin gauze or several other dressing materials, which I'll discuss subsequently. At the site, if you are a general physician, a general practitioner, and you are managing these burns, please do not apply any topical agents. Not that they are not required subsequently, and the burn surgeon will also not employ them. It is just because if you have applied a topical agent, the burn specialist will not be able to assess the depth of the burns, and he will have to remove all this topical agent to assess the depth of burns, and then only he'll be able to do something. And once in that process, he is going to damage the tissues further. So all you need to do is clean it with the cover it with a clean sheet and transport the patient to the hospital. Dressings, it is advised that burn patients who have suffered second degree burns, they should be dressed twice daily if you are dressing with any of these antibiotic creams. Generally, we are not able to manage that in the burns unit because of the overload, and in private settings also because it becomes very expensive for the patient, but at least all the patients should be dressed daily. So these are the agents which I have mentioned here, which we commonly use as topical agents. The ones in red are the ones which are commonly used for management of burns, but there is a caveat here that these agents which are mentioned in red are for managing burns because they penetrate the eschar, of full thickness burns, prevent the sub-eschar infection, which subsequently leads to septicemia and death. It is not that every small burn has to be managed by silver sulfadiazine or sulfamylon or with something like this. You can easily manage them with soframycin or a neosporin or maybe just povidone iodine. So silver sulfadiazine and sulfamylon, and these are reserved for extensive burns where there's large extent of deep burns, and we want to prevent sub-eschar infection so that the patient doesn't go into septicemia because of a sub-eschar infection. There are several dressing materials available to us, and it's very difficult to explain in such a short time which dressing material to use when. But suffice to say that it should generally be, if you are dressing burn patients in your clinics, then it should be a non-adherent dressing. It could be an ordinary Vaseline gauze or a Vaseline gauze which is impregnated with chlorhexidine, or you can use sometimes just Opsite or Tegaderm. Foam dressings and are used if in hospital setting when there is a large exudative loss which is taking place and you don't want to change the dressing frequently, so the exudate gets absorbed in the foam. Hydrogel dressings are there which keep the wound moist, and it's like a gel there on the burnt surface. It reduces the extent of pain and they hasten the epithelialization process. Similarly, collagen and alginate dressings are used in superficial and deep dermal burns to hasten the healing process. And you have other modern dressings like Suprathel, which are tripolymer dressings. Some of the newer silver containing dressing materials are there for last maybe 2 decades. And again, the importance of these dressing materials is in larger extent of burns and in deep dermal burns or superficial burns. First is that silver is the active antibacterial agent in this. It can be in the form of a nano silver, or it could be a hydrofiber which is impregnated with silver, or a silicon sheet which has like Mepilex, which has silver impregnated on it. A hydrofiber dressing will allow more absorption, and a nano silver will be more effective in controlling the infection. So these dressings are very special dressings. These are expensive dressings. They are used in a hospital setting. And one of the other advantages of these dressings is that you don't have to dress the patient daily. You can keep these dressings on the patient for 3 or 4 days and then change it. So These are the advantages of these modern dressings. So this shows that if there is a circumferential constricting eschar, it has to be released in this manner to allow circulation to take place. If it is an electrical burn, an escharotomy will not be sufficient and you may need to do a fasciotomy. You have to cut right up to the fascia so that the muscle bulges out, releases the pressure which is there on the vessels and the nerves, and otherwise you stand to lose the limb. There are two kinds of wound management subsequently which a burn team would indulge in. One of the modern ways of treating burns is excisional surgery. In this, there is less chance of infection, there is less morbidity, less extent of hospital stay, but you need to have adequate skin graft donor sites or availability of cadaveric skin or other xenografts, and you need a lot of operating time, lot of ICU care, blood transfusions. But this is the modern method of treatment, whether you have a second degree deep dermal burn, which I said will take 4 weeks to heal, or you have a full thickness burns. You excise this tangentially, or you excise the full thickness burns completely up to the facial level and apply a skin graft over it. The patient, this reduces the amount of inflammation which the patient may be having, and the graft takes and the patient heals very well and goes home early. But like I said, it requires a lot of operating time and ICU care and blood transfusions. And most of the government burn units are not able to provide excisional surgery to all the patients because it is too time consuming and it can consume all the resources of the hospital. The other method of managing burns is a conservative management. Although the mortality rates may be the same as excisional surgery, but it leads to more morbidity, more infection, and more use of antibiotics, longer hospital stay. And in this, you dress the patient, dress the burn wound till the superficial ones, they heal on their own, or the deeper ones, the eschar, the dead tissue, it separates because of the subeschar infection, and then you prepare the wound for skin grafting at a subsequent date. So I did mention this, that for second degree deep dermal burns, you do a tangential excision, excise it in this manner. For a third degree burn, you will excise up to the fascia and do the grafting. When you excise these wounds and you leave them open, you have to cover them. You cannot leave them like this. Either you cover them with the autograft, with the patient's own skin, or you cover them with a cadaveric graft, or you use a live donor. Sometimes the patient's relatives or the parents would give that. Or you have a pig skin or a bovine skin as a xenograft to cover it temporarily. Otherwise, you can imagine you would have caused horrendous problem to the patient, because you have created so much of raw area which will exudate and which will never heal on its own. So you cannot do an excision if you don't have adequate either autograft or a homograft or any kind of an expensive skin substitute like Integra or BioBrain there, which is there to buy the time and so that you can graft it subsequently. Amniotic membrane can also be used, and there are newer dressing materials like Matriderms, which are made from bovine collagen and elastin. So many advanced burn laboratories are there which produce cultured epidermal cells in the skin by taking a skin biopsy of the epidermis, and they separate the epidermis from the dermis and grow it in the lab and grow it as a sheet which can be applied after the excisional surgery. Similarly, you can have cultured dermal cells, or you can develop cultured composite matrix, but a cultured composite matrix is a long way off still for successful use clinically. Many of these burn patients, they can develop contractures. If adequate splinting has not been done during the healing, if you have allowed the wounds to contract, because the deep dermal wounds will contract, and the third degree burn, if it has not been skin grafting, it will heal by contracture. So you have to look into it that you graft them at an appropriate time, use splintage, and then early ambulation, active physiotherapy. And physiotherapy is actually to be done as soon as the patient becomes hemodynamically stable, so that if the neck is burnt, you give physiotherapy to the neck or to the extremities so that they don't go into contractures. After the healing has taken place, you need pressure garments and silicone sheets for scar management for better scarring. So these are the kind of splints that we use and pressure garments that we use in burn management after the healing has taken place, and they are extremely useful uh, additions to the armamentarium to prevent contractures and restore the function. Thank you very much.
Thank you, sir. Thank you for a great session indeed. Um, so I have a few questions. Most of the questions you have answered in your session itself. So I will just take a couple of questions, and and with that we can end the session. So one of the questions is, let's just see for questions which you may not have answered. So one of the questions is, if patient is conscious with active 25% burns due to boiling oil, is it needed to give an IV drip?
Yes. So boiling oil, you said boiling oil can be of can lead to very deep burns. It can stay on the skin for a longer period of time, and the patient needs resuscitation. Like I said, 15% burns and above in adults needs admission and resuscitation.
Right,
You may be, when I say resuscitation, it doesn't always mean an IV resuscitation. A 25% burns requires resuscitation, but you may resuscitate him orally and
right,
monitor the urine output. And you only give IV if the patient is not able to take enough orally, because the patient may not feel like taking enough that much amount of fluid orally. So you can start with oral resuscitation, because 25% burns is not much, but this patient definitely requires resuscitation.
right. There's one more question which you may have taken up in your session. It is talking about the role of physiotherapy in burn patients. Does physiotherapy have a role in burn patients?
Can you repeat that? I didn't.
Uh, Dr. Ayappan is asking about the role of physiotherapy in burn patients.
Role of physiotherapy, I did mention in the last couple of slides.
Right,
Physiotherapy is extremely important. So as
right,
soon as the patient becomes hemodynamically stable, which may be about 48 hours after burns, you have to give, if the patient has got neck burns, you have to see to it that first the patient is not nursed with a pillow on. Because if you have a pillow under the head, it will help in contraction of the neck. So you don't have to use a pillow. And then you have to, if the patient's arms are burnt, you have to see that there is a physiotherapist or somebody or nurse to give some exercises to the joints so that they don't heal by contraction. So definitely physiotherapy. And then if the patient has got extensive burns, then you need to give chest physiotherapy. If the patient is lying in the bed all the time, the patient will have problems with the lungs. So all physiotherapy is extremely important, and right in all burn units, physiotherapy in any form is started within 48 hours after admission.
right, sir. Last question would be, Dr. Balabhadra Ram is asking, can a patient be kept inside a sterile mosquito net for 2 weeks without dressing for second degree 25% burn.
Yeah. So what you are referring to is the exposure method of treatment of burns. The exposure method of treatment of burns was a concept which was there many decades back. It can be applicable occasionally in some patients depending on the kind of resources you have. Uh, in modern treatment, we don't recommend exposure treatment. It requires different kind of a monitoring. You just, I mean, if you look at it, it's a kind of an inaction. You put a mosquito net and then you forget about the patient and the patient will heal. So this is something to be avoided. So we all dress the patient, or we take the patient up for excisional surgery if the patient has got deeper burns, or we just dress the patient and resuscitate the patient. So this exposure method of treatment, we also use, in parts like if their face is burnt, if the genitalia is burnt, we can't dress these areas. So we cover them with antibiotic cream and expose them. And then they will either heal or we do something else. So this is where
Right.
the exposure method of treatment is used. The exposure method of treatment, which was advocated many decades back for the entire body, was a kind of an inaction which is not done anymore.
Right, sir. So thank you so much, sir. There are a lot of other questions. Most of them you have covered in your session, and we've also reached the end of the time. So with this, I would like to thank you once again for an excellent presentation and also responding to the queries from the audience. Thank you so much, sir. Thank you.
Thank you very much.
Thank you, sir.